Today, the topic of my presentation is controversies in clinical forms of polycystic ovary syndrome. Previous speakers discussed very important aspects of PCOS, and today I want to share with you Georgian view on clinical phenotypes of PCOS, which is, with all due respect, somewhat different from the international societies, but we don't to highlight some possible points of consensus. Polycystic ovary syndrome is a common disorder in reproductological, gynecological, and endocrinological practice, and due to high prevalence in Georgian ethnicity, it's reputed as a national disease of Georgian women. Over 2 centuries, interest to this disease has not diminished. This disease became widely known to medical community after the publication article amenorrhea associated with bilateral polycystic ovaries in 1935 by Irwin Stein and Mike Leventhal, and since this time, debates about the pathogenesis, diagnostics, and treatment methods of this disease cannot stop. Today, it is known that PCOS has multifactorial etiology, including genetic, intrauterine, and environmental factors. Over the years, international societies constantly trying to clarify the diagnostic aspect, and in 2018 international evidence-based guideline for the assessment and management of PCOS endorsed the use of diagnostic criteria. It was revised in 2023, and 2 out of 3 the following criteria: clinical or biochemical hyperandrogenism, ovulatory dysfunction, and polycystic ovarian morphology is required PCOS diagnosis. And recently, as my previous speaker mentioned, there was added anti-Mullerian hormone, high anti-Mullerian hormone. At the same time, there is exclusion condition, which can interfere or cause anovulatory dysfunction, anovulation, and androgen excess. PCOS is highly heterogeneous condition comprising hyperandrogenic, reproductive, psychological features, and can be evident in different clinical forms. According to the Rotterdam criteria, you know that 4 phenotypes are distinguished. Phenotype A comprises more severe forms of disease with hyperandrogenism, ovarian dysfunction, and polycystic ovarian morphology. Phenotype B also belongs to severe form and comprising only hyperandrogenism, ovulatory dysfunction. As for phenotype C, it's called ovulatory phenotype, but it should be mentioned that anovulation is a cardinal symptom of PCOS, and existence of this phenotype might be controversial. Phenotype D also is mild, without hyperandrogenemia, and very interesting that Androgen Excess and Polycystic Ovarian Society evaluated 16 potential phenotypes of PCOS, indicating the existence of different subtypes of current PCO phenotypes. American scientist Norbert Glacher proposed to replace these 4 existing phenotypes only into 2 entities: hyperandrogenic phenotype comprising A, B, and C phenotypes, and hypoandrogenic phenotype. The phenotypes A, B, and C exhibits high androgen levels throughout the life, but hypoandrogenic phenotype, in these patients with phenotype D, androgen levels decrease throughout the 10 years, from 25 to 75 years. The first entities characterized by metabolic abnormalities, and the second entities are characteristic by hyperactive immune system. Very interesting is proposals of Polish endocrinological medical societies, they recommended to identification of PCO patients with regards to dominant disturbances and consider metabolic, hyperandrogenic, and reproductive phenotypes. Recently, Italian scientists, Unfer et al., recommend the new classification. According to them, ABC phenotypes recognized as phenotypes, metabolic, endocrine origin, and phenotype D as disorders with ovarian origin, and they replace updated phenotype A as PCO, polycystic ovary, endocrine metabolic syndrome type 1, which consists of all Rotterdam criteria plus endometrium sickness. Phenotype C updated as PCO AMAs type 2 plus endometrium sickness, and phenotype B updated as endocrine metabolic syndrome. And very interesting is that they reputed phenotype T real polycystic ovarian syndrome without hyperinsulinemia and hyperandrogenemia, and with endometrial thickness more about 5 millimeters. The first three, the shear, the risk-related risk, diabetes, hypertension, and infertility, and the last phenotypes, shear, the risk, infertility, endometrial hyperplasia, and endometrial carcinoma. While these all phenotypes are very interesting, the new classification are very interesting, is updated. Since 1958, Jordania Institute of Human Reproduction in Tbilisi, Georgia, which was the first infertility clinic in the world, amassed a major experience in the management of PCO patients, and amassed with more than 20,000 patients, amassed a plethora of data, and based on several retrospective and prospective studies, and based on a Krimskaya's classification provided in 18th, we distinguished three main clinical types of PCOS, and let me elaborate to them. The first is primary polycystic ovary syndrome, the same Stein-Levelton syndrome, which is classical forms. Secondary PCOS, it's called central hypothalamic form, and combined polycystic ovary syndrome, ovarian adrenal form. Primary polycystic ovary syndrome induced by genetic defects of ovarian steroidogenesis, and the clinical manifestations are more severe and coincide with menarche. Excess weight with visceral obesity, with hyperinsulinemia, with hyperandrogenism is typical. Patients suffer from primary infertility. LH-FSH level is above 3, AMH is above 9, and typical polycystic ovarian morphology is characteristic. And secondary polycystic ovary syndrome induced by hypothalamic pituitary disorders due to disturbances in the ratio of biological active monoamines. The clinical manifestations are mild, moderate, and the onset of they developed after menarche. Pink stretches are very typical. Ovulation may occur. That's why patients may suffer from not only primary or secondary infertility. Moderate hyperprolactinemia, we talk about slight elevated levels of prolactins, is very common with moderate and mild ovarian hyperandrogenemia, insulin resistance. LH-FSH ratio varies from 2 to 3, AMH from 5 to 9. Typical ovarian morphology may not exist. As for combined PCOS, it develops due to the simultaneous presence of genetic defects of ovarian adrenal steroidogenesis. Mild deficiency of enzyme 3-beta-aldehydrogenase leads to simultaneously existing adrenal ovarian hyperandrogenemia, which is a diagnostic criterion of this form. It's different from mild forms of adrenal hyperplasia, which induced by deficiency of 20 21-hydroxylase. Obesity is not typical for this form. Athletic build with a narrow pelvis characteristic, primary or secondary infertility, and as I mentioned, simultaneously existence of ovarian and adrenal hyperandrogenemia is the main diagnostic criteria. It should be mentioned that PCOS is not stable or statistic condition as women advance in age. Many of the typical phenotypic features, especially hyperandrogenesis and ovulation, normalize with advancing age, and women who may present with fairly typical PCOS at young ages, by older ages, may no longer exhibit those typical findings. The serum AMH level is elevated generally in PCOS patients and show a slower rate of decline with aging, but it does not mean that the reproductive window is extended for PCOS patients. On the contrary, patients may have high number of oocytes, but they have oocytes of poor quality. Questions regarding the phenotypes of PCOS raises questions concerning the best clinical approach for the management. And today it is known that management of PCOS comprising non-pharmacological and pharmacological approach with combined oral contraceptives, insulin sensitizers, anti-androgens, anti-estrogens, but additionally pathogenic treatment with dopaminergic medication for hypothalamic PCOS is recommended, and for a combined PCOS we recommend prescription glucocorticoids. And due to such modus operandi, ovulation cycle restoration is very high, reach 92%, and pregnancy rate is 78%. And after summarizing my presentation, we can conclude that 4 PCO phenotypes under the Rotterdam criteria are not based on pathogenesis and are not clinically or biochemically distinct concerning the treatment recommendation. Jordania Institute's 3 clinical forms of PCOS, primary, central, and combined, reflect the pathogenic version of their development, which allow to conduct appropriate treatment for each one. So, pathophysiological approach significantly increase efficacy of the treatment of PCO with reaching desirable goal in a more short time. Thank you for your kind attention.